Okay, so hopefully, I mean, this is quite a basic stuff, so that as long as we can know the basic well, so and you can recognize what is normal, so subsequently it will be quite easy for you to identify what is the abnormality, right? So for the next probably 30 minutes, we're going to look at some of the pathological example. So once you already know the normal, all right, then now you start to identify the abnormal. So maybe one of you can answer. They're all together. I think it's about eight questions, right? So I think you can take turn one by one, try to see whether after you could answer the question or not. Is it okay?
Yeah.
Right. So this is the first question. So can I know, what type of view it is?
Pericardial effusion.
Yes. So this is a pericardial effusion, right? So there's one important things that you can point out here is that when you look at the echocardiogram, so the very marked structure that is a pericardial effusion. But we also don't forget that looking into the chamber, go quite systematically, right? So we could see that if you could go quite systematically, that this is a parasternal long axis view, right? And sometimes it depends on when you analyze the echocardiogram, you can go from out to in or in to out, right? So when you look at it, very marked is that the significant pericardial effusion, but don't forget what is inside the heart, right? So a lot of time I like to see from the chamber itself, right? So when you look at the chamber, so the left ventricular chamber, right ventricular chamber, and the atrium, there seem to be a bit relatively slightly smaller volume, yeah. So if you compare to the normal one, yeah, so the relatively smaller volume. So after we look at the ventricular size, the aortic size, then you try to look at the valve. The valve structure seems to be okay, open quite nicely, right? Then after that, you look at the ventricular wall, right? Whether they are contracting nicely, yeah, it seems to be have very good contractility, okay. Then look at any other structure anomaly. Look at the septum, okay. The septal wall seem to be quite intact, all right. And then you look outside, all right. So anyway, when you look outside, there's significant pericardial effusion. Also, sometimes we need to look at is how the heart is pumping, right? You see the heart is pumping quite nicely, regular rhythm. Sometimes we can detect any arrhythmia to the echocardiogram itself, right? So it's nice to go systematically, right? And importantly, that and one had to say that this is whether it is a pericardial or a pleural effusion. So sometimes we use the aorta to differentiate, right? So it could separate the heart from the aorta, so there will be a pericardial effusion. So if it adheres closely to the heart, the aorta, the effusion is outside here, there will be a pleural effusion. Okay. So this is a 4-chamber view. Okay. So anyone want to try?
Okay. One doctor comment is have a pericardial effusion and maybe have IHD, atrial septal defect.
Oh, okay. Yeah.
Maybe.
So what?
But I think in a view, I have a comment. I think a large pericardial effusion with deep brains, and I don't think so. The patient have ISD.
Yeah.
Yes, that's true.
Okay. So so this so let's go systematically like what we did just now. So you can go out in or in out, right? So the one that very obvious now we comment first. There's a significant fluid outside the heart, so there's a pericardial effusion, right? So what special thing is that there's a lot of like a spider web, right? A lot of spider web things around the pericardial effusion. And also when you look at it carefully, the fluid here is not clear. There's a lot of particle inside, okay? So it's suggestive of exudative fluid with some fibrin. Okay, So having said that, then after that, very importantly is that when the patient have a pericardial effusion, we want to know that whether it is tamponade or not, right? So in order to see whether the fluid accumulated around the heart cause tamponade or not, we need to look at the chamber size, right? So we can come, now let's look at the chamber size. The chamber that usually going to compromise is the right atrium. So this is the right atrium, left atrium, left ventricle, right ventricle, okay? So when you look at it carefully, the atrial size, the atrial structure is a bit different from the normal one, right? What's the things that which is a bit abnormal is that it is seen to be like compressing. The wall is actually compressing. So when the wall compressing, which means it shows that the pressure around is quite significant until it is slightly more than the atrial pressure, right? So this suggestive of this pericardial infusion is causing significant tamponade to the heart. Okay, then after that, similarly, we look at the valve. The valve seems to be quite okay. And then we look at the septum. Septum seems to be okay, although you look a bit slightly deviated, it's not straight. And then after that, we look at the contractility. The contractility is okay. So we can conclude from this view that this child have pericardial effusion. Most likely is a pericardial empyema. Why you say it's a empyema? Because you see that there's a lot of or some exudative collection. You could say that there's some sediment and then some fibrin, okay? And also we could conclude that this effusion has caused significant cardiac tamponade because of the left atrial is start to become become compromised. Okay, right. So the second question, right? So this is a long axis, okay? So this is a normal patient, okay? When you look at the normal heart, we look at the chamber size, okay? Chamber, left atrial chamber, left ventricle chamber, right ventricle chamber. Look at the valve, okay? Look at the valve, look at the wall, look at the contractility, okay? So as compared to this one, yeah? Do anyone want to try?
Then you think that the patient have LV dysfunction, systolic dysfunction, and the patient also have a pleural effusion.
Okay, all right. So, so when you look carefully, so we go systematically. Remember, we start from the chamber size. Okay, so this earlier on we talked about left atrial size and the aorta. Okay, the aortic outflow. Right. We say that hopefully most of the time they will be about nearly equal in size, but we look at it carefully here. So aorta is here and left atrial is here, right? So it seems like left atrial is slightly big, right? Yeah, so slightly biggish left atrial. Okay. Then after that, we go to the chamber size here. Okay, look at the chamber size, the left ventricular chamber here. So this is very big chamber, okay, right? Yeah. So this chamber is relatively small. So that means there's some significant dilatations over the left ventricular chamber, okay? So that is in terms of the chamber size. So the chamber size tells us that the left chamber is dilated, right? So after that, we look at the valve, okay? When you look at this valve is very happy. This is a, okay. So this is a very happy mitral valve, open out nicely, right? And then you see that this leaflet, okay, when they contract, is nearly touching the septal wall, okay? But when you look at this mitral valve, okay, this mitral valve doesn't seem to be very happy. No? It doesn't open very nicely, all right? And when you look at it carefully, this leaflet did not, it appear very, very different from this leaflet, okay? Because this leaflet did not really touch the septal wall, all right? So it didn't touch the septal wall, which means this is a very important sign of poor cardiac contractility, right? So when you see that the mitral valve can touch the septal wall, so it's good contractility. When this one, it doesn't touch, it's a poor contractility. Okay, and you look at the chamber size as well. So this normal chamber size usually is like a ice cream cone shape, right? So in the dilated heart, so sometimes the chamber is look like a cuboid. Okay. Okay, right. So and the other thing is that we look at the contractility, right? So this is a septal wall, this is a lateral wall. So when you look at these two, they are nearly kissing each other, right? The ventricular wall nearly kissing each other. That means good contractility. When you look at these two wall of the left heart, okay, it doesn't seem to be meeting each other. So it shows that quite significant left ventricular impairment. So very importantly, we pointed out that this is a effusion. When you look at it carefully, this is some of the consolidated lung. Okay, so there's move in and out, move in and out. Yeah. So this is a 4-chamber view. Okay.
Okay.
Yeah.
Dr. Sơn have a comment. Dr. Sơn thinks of maybe the pressure of the right ventricle higher than the left ventricle pressure, so the ventricular septal defects shift to the left side, and Dr. Sơn thinks the mitral valve have abnormal mitral valve. Yeah.
Okay, so this is a 4-chamber view, right? Yeah. So when you compare the 4-chamber view here and the 4-chamber view on the other side, okay, so what we notice is that all the chamber here are very too well filled. I mean, they seem to be very packed and tense. Okay, you look at this, right? So this is when you contract, the fluid can come out very nicely. It gets smaller and bigger, smaller and bigger, right? For this one, when you look at it, the anomaly that you see is that the chamber size did not vary very much every time, although despite systolic and diastolic. So which means that there's a lot of fluid, fluid in the heart. I mean, up to the extent that the heart they cannot really empty very well. So all the chamber are all big. Huh? So this is from the first instance. All the chamber are big and not much of variation in terms of the size. Okay, so that is in terms of the chamber. But otherwise, when you look at the right, left, compare left and right, they are nearly equal. Yeah. So which means nobody win. Huh? So all of them actually are two very well filled. Huh? So no one is dominant than the other. Yeah.
Yeah.
Okay. So so that is in terms of chamber. So we look at chamber 2 filled, and then when you look at the valve here, the valve we see here, the mitral valve here, and then the tricuspid valve here. As you could compare, so this same thing. The mitral valve did not open very happily as compared to this one. Huh? This one could open happily. This one could nearly touch the septal wall, although this attempted to, but not all. Yeah. Okay. So it shows that there's impair in contractility. Then let's come to the muscle. Okay. So this is a septal wall. Okay. Ventricular septal wall look quite okay. Right. This is atrial septal. Huh? So they're probably missing something there. All right. So you see that maybe there's some defect here. Huh? And the next step is that we look at the contractility, right? So let's look carefully the contractility here, okay? So most of the time when we contract, these two walls will come together. Huh? This one and this one will come together. Like for example, this one during contract, this septal wall will come together to the lateral wall, okay? Come together. But when you look at it carefully, it actually didn't come together. Huh? In fact, when this one tried to go in, this one tried to go up. Try to go in, try to go up. Can you appreciate that?
Okay.
So after these two views, then we can. The important thing is that we are doing point of care ultrasound. So we want to. How are we going to use this image to help us? So starting from the chamber size, we know that these chambers all are dilated. And then what does it mean that chamber all are dilated? They mean they probably have a lot of fluid already. So probably fluid is not a good thing to give to this patient. And then when you look at the contractility is poor, all right? So when you look at this heart, contractility is poor. So our main treatment will be not the fluid now, but it's the inotropic support in order to support the heart. Yeah. Okay. So now we go to the third case, okay?
Yeah.
So same thing here, all right? So we look at the long axis, and this is a normal patient, okay?
Yeah.
Looking at the flow, okay? Remember just now we studied about the Doppler flow, red color, blue color, all right? So this is another patient, right? The patient's ultrasound, okay? Long axis, okay? So now let's go again systematically for the chamber size, all right? So when you look at the chamber size, left atrial chamber as compared to here, huh? The aorta outflow, right? So we see that the aorta is the left atrial is big, okay, all right?
Yeah.
So and we look at the left ventricular chamber size, okay, and then as compared to here, normal as we say just now, it look like a cone shape, right? But this left ventricle is very big, huh? Until maybe it was square shape. Similar thing, the right ventricular chamber is also very big. Huh? Okay, all right. So the other thing is that now after the chamber size, then you look at the valve, right? So comparing this valve, right, this mitral valve as compared this mitral valve, right? So this mitral valve also hardly open very much, okay, as compared to this one. So you notice that this mitral valve is abnormal and the contractility is poor because the mitral valve did not hitting the septum as compared to here. Okay, so when you look at the flow, right, so there is this is a red flow, but they see the blue flow here. So this blue flow, that means the flow is not the normal pattern anymore. It jet back, okay. So when it jets back, which means incompetent mitral valve, all right. So there's a mitral regurgitation. Right, and we look at the contractility. So the ventricular wall. So this one casing each other. This one is very much dilated. Did not even touch each other. Okay. So similar things. Okay. So this is a 4-chamber. Okay. You could see that the atrium or ventricle are all dilated. Okay. Mitral valve not pumping very not open out nicely, okay, right, and then the contractility is very much impaired, right. So when you see this in our day-to-day practice, patient coming with respiratory distress, hypotension, when you do the ultrasound of the heart, you look at this, which means it tell you that the patient had adequate, probably have what the patient probably need is inotropic support rather than a lot of fluid.
Yeah.
So this is a 4th example, okay.
Yeah.
Yeah. So this is a 4-chamber view. Anyone want to take?
Okay. Okay. The one doctor comments have a tricuspid regurgitation.
Yes, very right. Okay, so this is left atrium, left ventricle, right ventricle, right atrium. Okay, so remember we look at the chamber size, or quite okay, all right. The mitral valve, okay, all right. And then the tricuspid valve look okay. The septal wall look intact, okay, right. When you look carefully, yeah, very good. Yeah, we have a tricuspid regurgitation, okay. So when you see carefully this septal wall, okay, so there is a turbulent across here, okay. You see that the turbulent across here, okay. So so there's a turbulent across, and then there may be some defective things there, okay. So actually maybe it's a AST or a PFO over this side, and yep, you're right. It's as a tricuspid regurgitation, yeah.
Yeah.
Okay. Okay, so this is a short axis. Okay, so as we discussed earlier on, so you because the flow of the aorta, the pulmonary artery. So this is a short axis. This is aorta. This is right ventricular outflow tract, pulmonary valve. This is a main pulmonary artery. Yeah, right and left pulmonary branch. Okay, so when you put the color Doppler across this side, you could see that there's a good flow across, mainly blue, right? So if you, this is another patient here, so we could see that mainly blue, but sometimes you can see a little bit jet here. Okay, so this is actually a small jet due to PDA, right? So this is especially in neonate, right? In neonate, sometimes this is quite common. Okay, and on top of that, because there's a bit of tissue thymus here. Okay, so important that in the patient with any cardiac problem or neonate, we would like to see any thymus present. Huh? So if it associated underlying cardiac anomaly without the thymus, so it's suggestive of syndrome, underlying DiGeorge syndrome. So this is another view, okay, a short axis, okay. There's another jet flow here, which is suggestive for PDA, yeah. Okay. So this is example 6, okay. Anyone want to try?
Dr. Son have comment, have the person have VSD.
Okay, all right, good, yeah. So, yeah.
Membrane VSD.
Membrane VSD.
Well done.
Well done.
So I think so. All right. I think maybe I have gone quite too.
Trên cái hình ảnh này có phải thông liên thạch không thầy ơi?
Yeah. Dr. Son comment, and the one doctor have comment, then the person have VSD.
Yeah. Anything else besides the VSD? Basically, yeah, correct. So there is a significant VSD, but as we said, we go systematically, right? So now you look at the chamber size, okay? So there's a significant difference in chamber size. Yep, no doubt there is a VSD, right? So whether this VSD causing any problem or not, right? So now when you look at it very, the thing that really impressed us a lot is that the left atrium is much bigger than the right atrium. The left ventricle is very much bigger than the right ventricle. Okay, so which means as one chamber is much bigger. Okay, right. On top of that, you look at there's a significant large perimembranous VSD. Okay, right. So this has been significant overload. This child have been failure. In left side dilatation, okay, with the VSD. Very good, okay. Okay, now, yeah, so this is a long axis, okay. Yeah, I think same thing, all right. So there is a defect here, yeah. So same thing, we start from systematically. So this is very huge atrium, okay, huge left atrium, which is much bigger than the aorta, okay. The ventricle quite big, okay, and then but the contractility is still quite good, okay, all right. And you see that there's a defect here, okay, the defect over this side, okay, and when you do color,
okay.
Okay, so this is the normal Doppler that you see. So when you see that there's some abnormal jet flow through the hole, yeah, you know that there's some abnormality here. So with that, you know that this child had significant VSD, and then the VSD had caused significant failure with really large and dilated left heart. Yeah. So so this is a color Doppler. Okay.
Yeah. Rồi, anh chị nào có comment gì không ạ?
Then this is a long axis.
Rồi, đây mặt cắt mặt cắt đấy trục dọc.
This is a short axis.
Yeah. Okay. Well, after we discussion, we have a comment. The patient have the TOF.
Yeah, very good. Yeah. So let's count now. Go systematically again. So first of all, we look at the chamber size. Okay. So this chamber size. Okay, and as compared to this chamber, so the right side chamber relatively slightly dilated. Okay, is bigger. Right, it's slightly bigger. Chamber slightly bigger. Okay. So then we look at the muscle, the ventricular wall. Okay, muscle. This is very thick. Okay. So there's a right ventricular hypertrophy, right ventricular hypertrophy. Okay, then there is a VSD here. Okay, there's a VSD because there's a discontinuity of the thing. Right. So this one demonstrate the color mixture. Okay, so there is a VSD with a color mixture here. Okay, right. And then when you look at this is a long axis. Compared to our normal long axis, so what we call it, the septum will be connected at the edge of the aorta. All right. So this is the VSD. This is a large VSD, and you see that the muscle wall is very thickened. Okay. And then this is the aorta. All right. So when the septum was seated in the midline of the aorta, we call it overriding of the aorta. So this is overriding of aorta. Okay. And here, this is short axis view. We expect to see the pulmonary valve here, but you couldn't see any pulmonary valve here. Okay, right? So in fact, you see that there's some narrowing here, here. And when you look at the color Doppler, okay, so it's quite haphazard. Okay, a lot of turbulent flow here. Okay, a lot of turbulent flow, and then sometimes you can see the red color. So this means is the flow direction is bidirectional. So this is a pulmonary stenosis. Is maybe a dysplastic valve or supravalvular pulmonary stenosis. The point I want to bring it here is that so if you know what is normal, right, and then after that, if you can compare what is normal to the abnormal, our purpose is not for us to say to diagnose this is a pathology of Philip. Our purpose as a POCUS is to say that yes, this heart you have the child with that low saturation but otherwise look well. This heart look very abnormal because it is the shape and the position is out of the usual normal pattern. Hence, you could subsequently refer to the cardiologist to further investigate and then not to rush into the desaturation. Yeah. Okay. So yeah, I think this is the last one. Yeah.
It gives me have an idea. I think the topic is very long. So I think after the sample, I think we will stop here.
Sure.
Sure. We continue at the next.
Sure.
Yeah.
Can.
Yeah.
Okay. Take time to absorb it. Look at all.
Yeah.
Sorry.
Okay. We will continue with the last sample.
Can. So this is a long axis, parasonal long axis view. So remember, so we try to learn what is normal first. Okay. So and on this side it is normal. Okay. And then this side is abnormal. All right. So let's say that this child presented to you at 3 weeks old, and then sinus desaturate. So you put the ultrasound port parasonal long axis. This is what you see. So what's the thing that you see here?
Yeah. Dr. Dong comment have a tricuspid regurgitation and the hypertrophies of the right ventricle hypertrophy, and Dr. Dong think maybe have pulmonary hypertension.
Okay, so now let's back to approach again. So we look at the chamber. Okay, so now this is the atrial chamber. Okay, this is the atrial chamber. So the atrial chamber is quite big. Okay, whatever that you see here, so this is a ventricular chamber. So what is missing here? The thing that we miss is the septum. Okay. So you cannot see any septum here. This is a long axis, but you cannot see any septum here. Okay?
Yeah.
There's no septum here, right? So, and then you see that there's a valve. Yes, there's a valve. Seems like maybe there's a tricuspid valve, or maybe a mitral valve, sorry. It's a mitral valve. It's a long axis mitral valve. And then there's a regurgitation. So you have like a common chamber. So one big chamber and then one big chamber without the septum. Without the septum, okay? So it'll be easier for us to see on the next one.
Yeah. The next one. Dr. Dong.
Thông xạ sẽ tắt à? Đúng không?
Yeah. So So when you go again to compare, remember we recognize the normal and then see what is abnormal. So when you see here, so we don't see 4 chamber, so we only see 1, 2 chamber. Okay, so 2 chamber. So we don't have the septum. Okay, we only have 1 valve here. There's no one half here. Huh? So this is a univentricular heart. Yeah.
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 One ventricular heart.
Yeah. Univentricular. Univentricular
yeah,
heart.
Univentricular heart.
Yeah.
Thì
So remember,
okay.
this is basically to we're not teaching to identify to get the diagnosis, but then the main thing is that so we identify what is normal, but when you see that this is something abnormal, so we know that the desaturation or any abnormality is mainly due to the heart problem. Yeah. So our concentration that is to identify what's the actual issue in the patient with desaturation. So when you do ultrasound heart, this is what we see. So it suggests to you that this is maybe a heart problem. Hence, we need to refer to cardiologist for further evaluation. Yeah, we're not teaching that to get the diagnosis, but at least identify the normal chamber, right? So at least we know that there's only 2 chamber, right? So when they see that there's 2 chamber, then it's equivalent to maybe a univentricular heart, and it is most likely a cyanotic heart. Hence, the saturation that the management is said that saturation will not be aiming too high, yeah, in our day-to-day practice, yeah. So that we went through the basics probe and then the basics window and basic view. Hope that this will help. And then when you analyze, it's always analyze. If you make into a habit of looking into the chamber, looking into the valve, looking into the septum, looking into the contractility, looking into the pericardium, the kind of systematic approach. So when you have this kind of systematic approach, and whatever that you encounter, and then you slowly build up, and then you do practice every day. So from there on, then you will learn with time.